So with that, it's my pleasure today to introduce Dr. Ifeolu David, a physician and scholar, currently an MSF fellow in the Department of Epidemiology at the University of Michigan. He earned his PhD from the University of Missouri, Columbia, where his research focused on health disparities, social and behavioral determinants of health, and infectious diseases. Prior to his academic career, Dr. David was involved in clinical care and disease surveillance during the Ebola outbreak in Sierra Leone, working with both the Ministry of Health and the World Health Organization. This frontline experience shaped his research agenda, deepening his focus on infectious disease surveillance, outbreak response, and health equity. Dr. David's research has explored HIV and COVID-19 among immigrants, minority populations, and healthcare workers in the USA, South Africa, and Sierra Leone using a combination of qualitative and quantitative methods. His interdisciplinary approach blends clinical experience, public health knowledge, and community engagement. Dr. David seeks to advance epidemiologic research through interdisciplinary collaboration and team-based approaches, addressing critical health disparities through evidence-based interventions. His current work emphasizes preparedness for future public health emergencies and explores aspects of infectious disease prevention and vaccine hesitancy. Please join me in welcoming Dr. David to the podium. Thank you.
Yes, good evening, everyone. It's nice to see familiar faces. And yeah, that was a pretty nice introduction. Thank you. Yes, so I'm glad to be here today and just want to share my work with you guys, share my experiences as well. So today I will be talking about my work in Sierra Leone specifically. It's relevant because it's part of my global health focus. The timing of this presentation is also quite relevant given our political status. It seems we always need some form of a reminder of why global health work is important, and this is a good opportunity. So, just a minute. Oh, yes, okay, got it. So my talk today is going to follow this outline. I'm going to dive a little deeper into historical perspectives, just shedding light on how we got here in the first place. So a lot of health conversations have been focused on the current state of events. And I feel for a very long time, we haven't had opportunities to just go back in time to see how we got here. And so I'm going to spend some time talking about history. I'm also going to talk about the health system in Sierra Leone, which is where my research focuses for the most part currently. I'll shed some light on how experiences during the Ebola outbreak kind of set the health system up and how it leads to my COVID research in the region. So that's going to be how this goes. And yeah, we'll see. So brief history. The history of Sierra Leone goes back to many centuries ago. And originally, Sierra Leone was inhabited by settlers from West and Central Africa. And I have the map of Africa somewhere. I will point it out when we get there. But Sierra Leone is on the west coast of Africa. It's a very small piece of land, kind of around 28,000 square miles. But the population is about 7 million currently, and it was smaller back then. In 1462 was when Sierra Leone was first, quote unquote, discovered. And at the time, it was discovered by Portuguese sailors. And one of those leading those expeditions was a guy called Pedro da Sintra, who kind of had the opportunity to sail across the Peninsula Mountains in Freetown, and his experience was why he named the region Lion Mountains. It is a Portuguese word that it's derived, so we call it Sierra Leone now. But that's kind of where the name originated. But this was many centuries ago. At the time, people actually lived in the region. So it's been reported in history as discovered. And that's why I did mention quote unquote, because of course, people had discovered this region prior to that. But in 1672 was when transatlantic sailing was a big deal at the time. And the British interest also became apparent in the region. Notably, Sierra Leone has a lot of minerals, so the attraction to Sierra Leone for trade was very much well warranted. And this was also around the time when slave trading was becoming a thing. So whilst trade in goods was happening, the dynamics shift pretty fast to trade in humans. So Sierra Leone had a huge history in the slave trading, and part of the image we see here is one of the regions where it was a hub for transporting humans. So this is Bones Island. What we see of Bones Island today is just kind of a historical reflection of what it was. Previously, we still get to see some of the shackles lying around. It's a history that has been kept intact just because of its relevance to our past. And during around the 1700s was when slave trade was becoming frowned at globally. So at the time when slave trade was abolished, Freetown was a piece of land that was acquired to resettled freed slaves. So in 1792, March 11, Freetown was founded. And Freetown was founded by a group of 1,200 slaves that were transported from Nova Scotia. And now the slaves or the freed slaves, to be specific, in Nova Scotia were slaves who had escaped from their American masters during the Revolutionary War. And at the time, the British Royal Army provided kind of a safe haven where slaves who managed to escape and join the British Army automatically got their freedom. Yes, so a lot of slaves followed this migratory pattern. Some were successful, some were not so successful. But in turn, they also got to fight for the British Army. Of course, this was a war the British lost, and a lot of these slaves were moved to Nova Scotia, where they were named British loyalists. However, Nova Scotia was pretty harsh because of the weather. And when Freetown, an arrangement was made in Freetown where this piece of land was bought from the local indigenous folks. It was pretty cheap at the time. So there was an exchange of goods, namely irons, clothes, tobacco specifically at the time was a huge commodity. But the total value was thought to be around £60. So that's pretty cheap. That's a better deal than the one we got for Alaska, I guess. Yeah. So the first group of slaves were returned in 1792, but around the 1800s, more slaves were also resettled in this region. Specifically, the most notable group among those freed slaves were the Maroons. And for our historian colleagues here, we know the Maroons were freed slaves who originated from the Caribbean, specifically Jamaica. And during the Spanish-British War, Britain took over that region from Spanish, and during that period, those slaves escaped from their masters and they wanted to be independent. It wasn't easy because the British also wanted to have authority over this group of freed slaves. So there were what we call the Maroon Wars in history that happened during this period, just because these were slaves who wanted to really be free, and British forces at the time needed their human resource. But they were their prowess in war was really relevant, so much that the British Army had to have a treaty with them sometime in the 1700s, and that treaty lasted for a while. But there was a second war again, which they lost. The Maroons lost this war, and a lot of them were deported to Nova Scotia. And being deported to Nova Scotia and having Freetown as a safe haven paved the way for their transports from Nova Scotia to Freetown. I go back in time with this history just to give some form of information on what the population in Sierra Leone looked like, how far this group of people have come. So not so long after relocation to Sierra Leone in the 1792 to 1800s, this was when British influence in Freetown became more prominent, and it was thought to be necessary for colonization to happen. So Sierra Leone became a British crown colony in 1808. Specifically, the colony was mostly Freetown because other parts of Sierra Leone were literally independent. They were being ruled by traditional leaders and they had their thing going on. So trade continued between locals and British, but then it became quite important for the British to have some form of authority over the inlands in Sierra Leone, not just Freetown. So Britain declared the other parts of Sierra Leone a protectorate in 1896. And what this meant was Britain had kind of a rule over activities in these regions. They did so via proxies. They installed paramount chiefs who were kind of seeking their interest in all of these regions. And they also put in place things that were not very comfortable for the local settlers. And one notable thing was the hut tax war. So because people lived in huts, that's why it's referred to as huts. But the tax was to tax every hut 5 shillings at the time annually to be paid to the British administration just for occupying the land their ancestors had occupied for centuries. Obviously, this wasn't something that the people felt comfortable with. And for people who had like larger huts, if it's a hut that has like 4 rooms, the tax was going to be 10 shillings. This was pretty expensive, especially in other regions in Africa where colonial rule happened. Like in Southern Africa, the hut tax was like 3 shillings. So I'm not so sure why they thought it was a good idea to raise the bar that high in Sierra Leone. So it led to a lot of local unrest, civil unrest, and one of those was the hut tax war that was led by a local leader, by Bure. So the war was pretty successful for like 5 to 6 months. What they did was basically cutting down trade lines for colonialists, and they did well. And after 6 months, they couldn't do more. A lot of history says Baibure was betrayed by fellow Sierra Leoneans. Who knows what happened? But it was obvious that the British had a lot of more military power than what the locals had at the time. So after the hot tax war was quenched, the British colonial folks had all the authorities to do whatever they want in the region. And they did use those authorities to do a lot in terms of minerals, trade, and all those things. And for a very long time, colonial rule was peaceful, mostly peaceful because people respected the rule of law. But why this is relevant to health, and this brings the narrative to health disparities again, was the fact that because colonial rule mostly, especially the administrative part of colonial rule, was happening in Freetown, a lot of the colonial structures were installed in Freetown. Healthcare at the time was focused solely on colonial interest. So therefore, health facilities, things like hospitals, clinics, where you could only find those in Freetown. And even in Freetown, they were only accessible to British representatives or elites, Creoles, who are the freed slaves who are working with British representatives. So which means the rest of the protectorates at the time never really had any infrastructure for health, never had any form of healthcare services. They depended mostly on their traditional methods, which worked out sometimes and sometimes don't necessarily work out. But what this means was there was already health disparities in this region during this time. And it comes down to the fact that colonial rulers were more interested in their interest, but also some form of lack of knowledge, because it was a lot of the disease conditions that were happening at the time were being blamed on the locals. It was thought the locals are the ones causing the disease outbreaks because of the way they were living their lives. So during the colonial rule, because there were lots of problems with health, disease outbreaks, there were efforts to have some form of healthcare infrastructure, especially in Freetown. So in 1892, British missionaries were more interested in making sure there was some form of healthcare. So the first hospital, which was called Princess Christian Maternity Hospital, was established in Sierra Leone, mostly focused on maternal and child health at the time. And then in 1912, that's about 20 years later, the first general hospital, which is Connaught Hospital, was also established in Freetown. Connaught Hospital was named after Prince Arthur, who was the Duke of Connaught in England at the time. But of course, medical services in this region wasn't really adequate. And this was the case until 1961, when Sierra Leone gained independence. So what this means is, throughout colonial rule, there wasn't really a health infrastructure in Sierra Leone. And then, during independence, of course, this was time for a lot of infrastructure to be rebuilt. In 1961, when Sierra Leone got independence, life expectancy was 32 years, which was pretty low compared to what you'll find in many other regions at the time. And this is mostly because colonial policies had not prioritized healthcare for locals in the region. And rural areas never really had hospital facilities. This is kind of a little chart that shows how much life expectancy improved post-colonial rule. So in 1960, we could see life expectancy was below 35 years, and it gradually increased over time. And we do see a dip sometime around 1991 to 2000, and I'm going to explain why we have that dip, but it's mostly due to the Civil War. And then there is a significant rise since 2001 till now. So a lot has changed, a lot has improved over time since independence. So going back to the chart I showed earlier, just in 1991, when there was a huge emphasis now on healthcare, because since independence, there had been a lot of emphasis on economic infrastructure, on many other things like roads, road networks, and all those things. In 1991, when emphasis was placed on healthcare, that also was when the civil war started in Sierra Leone. The civil war in Sierra Leone was pretty interesting because it was shaped by a lot of foreign interest in minerals. You guys may have seen the Blood Diamond movie, which was inspired by events that happened in Sierra Leone. Sierra Leone became popular for diamonds. In the history, we've had tales of in places like Connaught, which was well known for diamonds. We've had tales of people waking up in the morning after like a heavy rain and seeing diamonds laying down on the ground. So diamonds were a thing that was really, really popular at the time. And this attracted a lot of interest in trade, but also lots of interest in conflict. So there was a conflict in Sierra Leone between 1991, and it lasted for 10 years. And that was a very long time to have a civil conflict. And during that time, a lot of infrastructure, both economic and health, also collapsed. So by the year 2002, when the civil war ended, Sierra Leone had also health infrastructure, economic infrastructure were also down to zero. So the country, both administrative and health-wise, had a reboot again in 2002. And these events are quite relevant because in high-income settings like the USA, we've had a health system, had a health infrastructure that has been there for a long time. They've had opportunities to build on works that have been done by previous stakeholders. They've had opportunities to improve the health system without regularly tracking back. And we see in Sierra Leone after 2002 was really when the health system started over again. There was emphasis on providing healthcare for individuals, not just in Freetown, but also across the country in many rural areas. This was going to be a very difficult task because health workers at the time, especially medical doctors, were not so many. The colonial rule never prioritized training local medical doctors. So all these activities had to be planned and implemented by the local government. So in 2006, Connaught Hospital was renovated and opened again to the public. The government also had to come up with a strategy where they had to be aware of what the capabilities of the health system was. So they had to follow this system where there are primary care units, which are meant to be just local healthcare posts. And then there are secondary healthcare units that are meant to receive referral cases that are pretty tough, get to those secondary units. And then there are tertiary healthcare units, which are mostly hospitals. That's where you'll find medical doctors, specialists who will attend to like really difficult issues. This was very helpful because it was not feasible to have medical doctors in every region in the country. And a lot of the tropical diseases in Sierra Leone at the time were diseases people understood. So malaria has been there for a very long time. So nurses could identify malaria. Nurses could actually treat for malaria as long as they have like a guideline. So the only time they get to refer is when they have a case of severe malaria or like some complicated form of disease condition, and then they could refer. So it does comes with a lot of cost savings. It comes with a lot of efficiency. And kind of that was how the healthcare system was structured. So what the image here is an example of a primary healthcare facility. It's mostly very small structures that has clinic rooms, rooms for delivery, and kind of serves a lot of the basic needs for the local folks. And if for any reason someone has a condition that requires surgery, they could be referred with an ambulance to one of the tertiary hospitals. So this system works. And therefore, in 2014, 2015, a lot had been done. And this was a very fast pace when we think of the healthcare system only started about 12 years ago in 2002. So by 2015, they've in Sierra Leone, they had like 1,184 peripheral health care units, and these are primary healthcare units, and then a few secondary healthcare units and some tertiary healthcare units. Just to explain this structure a little bit. So in tertiary healthcare units, that's where you find medical doctors, specialists, so people who do OBGYN, internal medicine, you find those people. You wouldn't find medical doctors in primary healthcare units. In primary healthcare units, it's mostly manned by community health officers, nurse, and people that are referred to as MCH-aides. So MCH-aides are not, they do not have a nursing degree, but they are trained, and they are trained in community health practices. So they could help with delivery of pregnant women. They could help, they do have a guideline. So they do have some information. They could help with prescribing malaria medications or administering routine clinical practices. And they are expected to refer cases that are complicated. So that's kind of how the structure was set, and it's still the way it's set up now. And this is relevant because it was only just a few years after the civil war that we had the Ebola outbreak in Sierra Leone again. And it becomes really interesting because even before the Ebola outbreak, there had been multiple outbreaks of infectious diseases. Initially, it started out with outbreaks of cholera and measles, and Lassa fever had been, they've been having sporadic cases in the eastern part of Sierra Leone. So Ebola was really coming at a time when the health system was not very well prepared. And this is also relevant because given the structure I just described, it means a lot of these peripheral healthcare units do not have the abilities to manage transmission of diseases like Ebola, which requires high level of biosafety and isolation levels. So what we found was health workers who are really interested in helping folks who are ill were putting themselves at risk. And they were kind of attending to patients without appropriate infection prevention tools. So, and it's been a long history of limited resources. So even before the Ebola outbreak, there were healthcare units who struggled with gloves and all those things. So when the Ebola started, it was really hard. And we saw a lot of disease transmission happening pretty fast just because people were putting themselves at risk and they were trying to help, but also getting infected. And they were taking these infections, getting infected at the hospital, taking the infection to their homes and infecting family members. And for a very long time, a lot of people who got the Ebola outbreak, who got infected, actually died. Yeah, so this is just a photo of community activities. On the right was a community that was quarantined. In this community, they had one case of Ebola, and it spread within a week. There were so many cases, they had to quarantine the whole community. This was me on the left doing one of the surveillance activities. We did these activities. We had to check on quarantine homes twice daily to make sure we pull out cases of Ebola as soon as they started having symptoms. And to give more context, Ebola actually started in Guinea. Guinea and Sierra Leone are neighbors. Guinea and Sierra Leone share very similar cultures, so much that you would think if it wasn't for colonial interests between France and England, these two regions should not be separated. So therefore, things like trade between Sierra Leone and Guinea has been happening for a very long time. And we see a lot of informal border crossing region. This was a photo I took in 2011. Yeah, my phone camera wasn't the best at the time, but I was standing in Sierra Leone and you could see Guinea just across the road. And Yes, so these informal border crossing regions were very common. So once the Ebola started in Guinea, it didn't take long to get to Sierra Leone. And because health system structures in Sierra Leone was really naive, we saw cases spreading. The first case of Ebola in Sierra Leone was in May 2014. And by October, this is what it looked like. So the red spots are new cases, and the black spots are areas that have had cases of Ebola previously. So it spread pretty fast. And at the end of the Ebola outbreak, which ended in 2016, Sierra Leone has recorded about 4,000 deaths and more than 14,000 cases. And these cases are thought to be underestimated because in the beginning of the outbreak, during the peak of the outbreak, when there wasn't much surveillance activities going on, a lot of Ebola cases and deaths happened that were not recorded. So just a brief timeline. I mean, Ebola started in Sierra Leone in May and ended in January 2016. So it was close to 2 years of hardship during the Ebola outbreak. And for many people who lived through this time, the common theme was fear of infection. The common theme was having family members or friends getting infected. And because Ebola was thought to be and it is very contagious, individuals who are infected are taken from their homes to treatment centers where they are not allowed to be visited. And for a lot of those folks who die, they are not allowed to be buried by their families, so which means they get to be body bagged and buried without family members seeing them at all. So which means for many families, once their relatives were taken from those homes, they never got to hear from them or see them again. So it was a traumatic period for many folks. And just a few years after the Ebola outbreak was when COVID was happening again. So COVID started around the year 2020, we know, and it was just 4 years after the Ebola outbreak. This was a time when I was doing my PhD in Missouri. I had been involved with a lot of COVID-19 research, both in Missouri and in South Africa. And I was very, very interested in going back to Sierra Leone to explore how, especially experiences of the Ebola outbreak, could influence some of the experiences with COVID-19. So far, I have conducted 2 projects in Sierra Leone, one which was part of my dissertation project, and one which I completed recently. And these are the 2 projects I'm going to share with you guys today. Yes, so this is the map of Africa below, and we get to see Sierra Leone being on the west part of Africa. It's really small, so as we can see from the map, and even though it's this small, population is about 7 million, but the history is rich. And I did decide to go back in history just to provide a lot of context on why the population in Sierra Leone is thought to be unique, why infectious disease and global health efforts are quite relevant in this region. So for my first project, I was keen on kind of exploring what those COVID experiences were among health workers. My target population was health workers because I knew they had experienced most of the odds of the Ebola outbreak, and coming back to COVID-19, those experiences could be significant. I was also keen on learning how, especially for places like the USA, COVID-19 was kind of the first experience for many folks with a huge disease outbreak. For regions like Sierra Leone, this was something that was happening just after Ebola outbreak. So it was going to be interesting to see how some of the lessons during the Ebola outbreak could have shaped their approach to COVID. And so this was something I was keen on. And this was also around the time when COVID-19 vaccine discussions was happening. And even though we do know vaccines are meant to help to protect us from diseases, COVID-19 vaccine was a controversial vaccine for many reasons. That was kind of out of control of health workers. But also we do know as well that health workers have a huge role in vaccine uptake discussions. In fact, CDC at the time recommended the use of trusted messengers, and in low resource settings like Sierra Leone, health workers were huge trusted messengers. So it was going to be really intriguing to see how these health workers really view the COVID-19 outbreak itself and also the vaccine. So as part of this project, I did a mixed method study, and I included 3 districts in Sierra Leone, which had the highest cases of Ebola during the Ebola outbreak as part of my qualitative study. But as I did the quantitative piece, I expanded this. I expanded to about 6 districts. So 3 of those highly affected Ebola regions, but also additional 3 districts that had the highest number of COVID cases at the time. So in the end, I ended up with 24 participants from the qualitative study and 1,001 participants from the quantitative study. And a big part of this study was informed by engagement with health workers, especially during the qualitative side, which was the first part I did, and had a lot of conversations with stakeholders and health workers. So I had 3 goals at the time, kind of exploring the experiences, thinking about perception towards infection prevention and control practices, but most importantly, COVID vaccine decision-making. So today, I'm only going to talk about the COVID vaccine and findings from the COVID vaccine uptake part of things. As part of my conceptual framework, I was using the 5C framework for vaccine hesitancy. This is because the 5C framework at the time had demonstrated very high relevance in predicting individual tendency to take up vaccines. And according to the framework, 5 constructs, which are confidence, collective response, calculation, complacency, and constraints, these 5 constructs are thought to influence decision-making when people want to decide whether they want to get vaccines or not. So what this means is that individuals are more likely to get a vaccine if they are confident that the vaccine works. They are also more likely to get the vaccine if they are interested in keeping everyone in their community safe. They are also more likely to get the vaccine if their calculation of risk versus benefit shows that the vaccine may be more beneficial than the risk they are taking. And they are less likely to take the vaccine if they are complacent. And they are also less likely to take the vaccine if they have constraints, things like financial constraints, things like access to the vaccines. So this framework had been very, very effective in predicting vaccine uptake. And as part of my work, I realized, indeed, a lot of the decision-making for health workers in Sierra Leone followed constructs of this framework. So the only unique thing I found was discussions around COVID vaccine were not entirely based on the COVID vaccine itself, but rather they were based on the brands of COVID vaccine they had access to at the time. So these were health workers. They knew they had some level of health literacy, but for a lot of these health workers, they knew in high income settings like the USA, people were getting Pfizer and Moderna. And now in Sierra Leone, they only had access to 2 vaccines, which were Sinopharm and AstraZeneca. So Sinopharm was manufactured in China, and for the most part of the time when it was being given in Sierra Leone, a lot of the health workers had issues, had trust issues, because they had not had information publicly on the vaccine trial process. So they were not very sure whether the vaccines were even tried in Sierra Leone or whether it was already approved. And going back to the historical, the history of Sierra Leone, it's hard to blame health workers for their lack of trust. So for many of these health workers, they had preferred other types of vaccines than the ones they were getting. and they had no choice. They had to make decisions based on those vaccines anyway. Another problem was the vaccines that were available in Sierra Leone, especially AstraZeneca. Health workers talked about the doses being already expired before they were brought to Sierra Leone, and people were being cajoled to still get those expired products. This was something I had doubts about when I had these conversations with health workers during my data collection process, and I had to reach out to some of the health authorities, and I found out it was true. So it turns out doses of AstraZeneca were shipped to Sierra Leone within the 90-day period of their expiration, very close to the expiration. And these doses, of course, were expired before they were used up, and they had to get advisory from WHO and Africa CDC that the vaccine products are still viable, are still safe up to 90 days after their expiration date. And this isn't really new with pharmaceutical products, may be true, but in the history of healthcare system in Sierra Leone, people have not been using expired medications, especially these health workers. The health workers know the system with pharmaceutical products. Once it goes to expiry, it's been moved away from the hospital settings for destruction. So it was very strange at the time that these vaccines, even though they had been expired, they were still advised on using these vaccines. So it caused a lot of issues with confidence in whether the vaccines were safe, whether the vaccines were good, but also confidence in the intention of individuals or high-income settings who were supplying these vaccines, whether they were really doing it with good intentions or not. So this caused a lot of hesitancy. Another part of the barriers health workers talked about was the constraints I just mentioned, because they couldn't get the exact type of vaccines they wanted. And between Sinopharm and AstraZeneca, they actually preferred AstraZeneca, but a lot of them could not get AstraZeneca because the policy at the time was you get Sinopharm if you are young or if you do not have any underlying health conditions. So as long as you do not meet those requirements, you get AstraZeneca. Okay. So AstraZeneca, if you are old and you have underlying conditions. Sinopharm, if you are young and do not have underlying conditions. A lot of the health workers I talked with were young and did not have underlying health conditions. So they were stuck with Sinopharm. So they had a lot of issues in getting what they wanted. Some of them did talk about complacency. They thought natural immunity was more effective in preventing COVID more so than the vaccine. But a lot of those conversations were based on how much of the benefit versus risk they felt with the vaccine. So, and this brings us to things like facilitators, which was health workers who believed they were safer with the vaccines than without the vaccines, did get the vaccine. And some of the health workers just wanted to have some form of vaccine collective immunity in the population. So they also felt they had a huge role in shaping those discussions. But one of the unique things I found in this study was the role of experiences. So it turns out, even though a lot of these health workers did not like the vaccines, in my study population, more than 80% of the health workers had got the vaccines. So a lot of these discussions around how much they dislike the vaccines were just these conversations they had before they get the vaccines. But they did get the vaccine, which was quite unique. I think it was a paradox because typically when people dislike vaccines, they just don't get it. And it was pretty strange in this population. And a big part of that was, as I probed further, was the experiences with the Ebola outbreak. And a lot of the participants talked about, during the Ebola outbreak, how many lives was lost, how little they could do in preventing infection exposure. And they felt they might be safer with the vaccine, more so than without the vaccine. So they did get the vaccine, even though they were not comfortable with it. So it was pretty obvious that the 5C construct wasn't really covering a lot of vaccine decision making in this region. So I concluded that an additional construct, which is experiences, both experiences with COVID-19 and experiences with Ebola, especially, might be playing a huge role in this population when it comes to vaccine decision making. And I had the opportunity of exploring this notion further with my quantitative study, which also had 81% of health workers who had got the vaccine. A lot of them got the Sinopharm vaccine, a few got AstraZeneca, and some of them were not quite sure of which vaccine they got because they didn't have a say in that decision. And most of them reported the reason why they wanted to get the vaccine was for personal protection, and so 70% thought personal protection was going to be huge in getting the vaccine. A lot of them talked about having lost, 30% had lost colleagues or family members during the Ebola outbreak, so they had some experience with the hazards of Ebola. And however, a lot of them were also concerned about side effects. Those concerns mostly delayed their decision, but didn't really stop them from taking the vaccine. What I found was education. Individuals with higher education were more likely to get the vaccine. Health workers who had direct patient contact were more likely to get the vaccine. Health workers who had Ebola experiences with families or who themselves were Ebola survivors were more likely to get the vaccines. What was pretty strange was the fact that even though a lot of these health workers were taking the COVID vaccines, only few, about 34% of them had got the booster vaccines. And this was because for most of these health workers, lack of awareness, they were not aware the booster vaccines was something they were supposed to get. And this was a time when we were still talking about booster vaccines for COVID. Now we are talking about updated doses. And what I found was in the region, the health promotion was focused on getting the initial 2 doses of COVID vaccines. And there was very little or no promotion of getting more doses like the booster vaccines. I wasn't sure, and health workers I talked with were not so sure why health promotion focus had not emphasized getting booster doses. A suspicion was there were not many doses of vaccines available anyway. So I think the priority was kind of focused on getting those first 2 doses. So this was interesting at the time. And one of the things I concluded was the fact that the health worker population in Sierra Leone were unique. Experiences has shaped a lot of the way they approached COVID-19, and in a positive way, because the Ebola experiences kind of helped with them making decisions that were more positive towards their health. And it felt like there were still existing disparities with COVID vaccine distribution globally. That was pretty obvious. So I followed up with my second project, which this time I was more keen on exploring how these findings kind of translated to individuals who are not health workers. Because with health workers, we know they have at least some form of formal education, they have a lot of health literacy. And the question is usually, is this finding representative of what you will find in the general population? My hypothesis was probably not, but I felt it was important to get some evidence. So for this study, I was keen on exploring how lessons from the Ebola outbreak kind of shaped the COVID experiences. I was also keen on assessing the role of formal education, especially because even among health workers, formal education had a huge role in vaccine decision making. I did a mixed method study again. This time, it wasn't as easy as with the health workers, especially because as I run the quantitative piece, because most of the non-literate population do not have a good understanding of English, this survey prompts have to be administered in person. So this was me with one of the pregnant women. I had to interpret, translate, ask these questions in Creole and get the response and tick which one was most applicable. So this was a lot more challenging than the health worker study was, but I thought it was very insightful, especially because in Sierra Leone, the population I targeted, which were petty traders, pregnant women, and I had college students, they were mostly there as a control group, but petty traders and pregnant women are not populations that people want to do research with, mostly because of their limited understanding of English. And a lot of the perspectives from this group have not been included in existing literature in the region. And as part of this study, I did find similarities with what I found in the health worker study. And some of those similarities was the fact that Ebola experiences indeed had shaped the way they approach COVID-19, especially in terms of prevention practices like hand washing. So during the Ebola outbreak, there were many practices around communities of having hand washing stations where people have to do some form of, it was mandatory at the time, it had to be enforced at the time. People have to wash their hands before as they move around the community. And people were reluctant during the Ebola outbreak, so it had to be enforced. And during the COVID-19 pandemic, those stations were there. There wasn't much enforcement, but people were very willing to do those practices. So, and as part of those conversations with participants, a lot of them did mention, well, these things come easy now because we had been doing this during the Ebola outbreak. So those were positives. Those were really huge positives. And some of them did take the vaccine, mostly because they wanted to protect themselves. They also wanted to protect their community. But complacency, just like with the health worker study, complacency was also had a huge role. And for the non-health worker population, they also talked about misinformation. However, I had a few findings that were unique to this group, which were findings I didn't see with the health worker population. So for instance, the non-health worker population, petty traders, pregnant women, they did not discuss vaccine brand. What they knew was COVID-19 vaccine. They didn't have issues with which brand they were getting. I wasn't very surprised just because we know health workers do have a lot more information than individuals who are not health workers. So this was quite interesting. For individuals who are not health workers, they talked about issues with accessibility, accessing the vaccines. Some of the individuals who had not been vaccinated actually wanted to get vaccinated, but did not know where to get the vaccines. But also, most importantly, for a lot of these individuals, this was the first time during their adulthood that they were going to be making vaccine decisions. They had never had to make decisions on vaccinations since adulthood. They were very familiar with concepts of childhood vaccines. So their children, they know their children have to get those vaccines. But it was pretty strange for them to be thinking about it as adults, to the extent that pregnant women had tetanus vaccine as part of their routine antenatal visit practice. They considered the tetanus vaccine as an injection. So for them, it wasn't really a vaccine, just because vaccine were things people get for kids, not for adults. So making decisions on COVID vaccines was really tough, especially given a lot of misinformation that was spreading. And in the end, I found, as part of the quantitative piece of my study, that COVID vaccine uptake was very low. Just 30% of the participants had got the vaccine, even though 92% of those participants did mention that they were aware of the vaccines being available. And this was interesting because this was quite low, very low, more than I knew. I mean, I expected the health workers to have got more. I mean, the vaccination rate among health workers to be higher, but I didn't expect it to be the difference to be this much. And of course, I found formal education had a huge role because individuals who had formal education, about 51% of those individuals had got the vaccine, but only 21% of individuals who had less than high school education got the vaccine. The reasons for not vaccinating for most of these individuals were personal autonomy. They just didn't want to get the vaccine. Some of them had access issues. A lot of them talked about fear of potential side effects. And among individuals who had got the vaccines, only 30% of those individuals also had got the booster vaccines. And this was in 2024 when this data was collected. So this was a time when the discussions around COVID vaccines had shifted in the USA to what we call now more updated doses of the vaccine. So we're talking about booster doses is it's like we are going back in time. And yet booster vaccine doses had not been available at this point. So I did have some form of conversations around general knowledge around vaccines. And for a lot of these individuals, apart from tetanus vaccines, they were not very familiar with other vaccines. Yellow fever has been a huge part of Sierra Leone history with infectious diseases. So people get to take yellow fever vaccines, especially when they travel. So yellow fever wasn't as new as a concept as with COVID and other vaccines. And yeah, and a big part of also what I found was the role of the Ebola experiences. So individuals who had received the Ebola vaccines, 94% of those individuals also took the COVID vaccines. So it felt like they were like more comfortable with the concept of vaccination. Also, among this population, 78% of individuals who identified as Ebola survivors, and these are individuals who got the Ebola, who got infected with Ebola and survived. So 78% of those individuals also got the COVID vaccine. So it was pretty interesting as well. So given these findings just between among health workers and non-health workers, my conclusions were vaccine hesitancy still remains a huge issue. It seems like a more complex phenomenon, especially given how discussions around vaccine uptake, especially with COVID-19, differs between regions. In Sierra Leone, I was more shocked with the way COVID vaccine was discussed, specifically based on brands rather than just the vaccine itself. It was pretty obvious that experiences, risk perception, and formal education does influence vaccine behavior. And I concluded that future health promotion strategies could increase vaccine promotion by leveraging past experiences. This was something that kind of worked in Sierra Leone because past experiences with Ebola outbreak shaped a lot of the ways people view COVID-19, but also improving health literacy. Health workers who had more health literacy were more likely to get the vaccines. Even among non-health workers, pregnant women who were more exposed to health information because of their antenatal routine visits were also more likely to get the COVID vaccines than those who did not. It also seemed important to enhance risk communication, but we still have issues with accessibility, which is something you would think shouldn't be an issue with a very relevant disease like COVID-19, and people still have access issues. From a global perspective, a lot of my findings from this study pointed out at disparities in vaccine distribution because it's been about 3 years after COVID vaccine became widely used, and still in places like Sierra Leone, Pfizer and Moderna vaccines are still not available. So it's vaccine distribution becomes a huge issue, especially again when I look at the booster vaccine discussions among participants. At least individuals in these regions are expected to have taken multiple doses of COVID-19 vaccines at this point. And I think a lot of us here in the USA have had that opportunity, and these opportunities are not yet available in these regions. From a global standpoint, it just means we are leaving some regions behind, and we are also at risk because who knows the next strain of COVID-19 where maybe originating from these regions that have been neglected. So I close my presentation with this remark, and I do believe that lessons from the Ebola outbreak and the COVID-19 pandemic in Sierra Leone does remind us that trust, education, and accessibility are at the heart of vaccine uptake. So as we prepare for future public health emergencies, ensuring equitable healthcare access worldwide, it's not just a necessity, but it is a global responsibility. So thank you very much, everyone.